Next up, we have Stephanie Cohen, who is an infectious disease physician and the medical director at San Francisco City Clinic. She completed her internal medicine and infectious disease training at UCSF, and today she will be discussing biomedical HIV prevention strategies and the DEMO project, which is a study of PrEP implementation at municipal STD clinics.
Okay, thanks, Trang. Can everyone hear me? Yes. Yes, okay. So today I'm going to be talking a bit about biomedical HIV prevention strategies. I'm going to start by reviewing why we need new HIV prevention strategies. And I want to point out these four strategies, which all somehow involve using anti-HIV medications for prevention. So these four strategies are post-exposure prophylaxis, pre-exposure prophylaxis, antiretroviral therapy as prevention, and microbicides. I'm actually only going to have time today to focus on primarily on the first two, post and pre-exposure prophylaxis. There are also other strategies that are considered biomedical HIV prevention, like HIV testing and, of course, STD screening, diagnosis, and treatment. I want to emphasize, though, that all of these strategies really should be considered biobehavioral and not just biomedical, because in order for these strategies to be effective, they also require behavior change. They require knowledge of the intervention, they require uptake. Many of these require adherence, which is a behavior that can be challenging for any type of health maintenance behavior. And in addition, in the studies that have been done of these strategies, they were all offered as a part of a combination prevention package that included counseling. So I don't want to pit behavioral versus biomedical. These are really combination strategies. And then lastly today, I'm going to talk a bit about the DEMO project, which we're very excited launched about 6 weeks ago. And I'll be telling you about that as well. So why do we need new HIV prevention tools? As many of you may know, MSM are the only risk group across the country for which the number of new HIV diagnoses has continued to increase over the last 4 or 5 years. The number of new diagnoses and injection drug users and heterosexuals has been trending down. This graph here looks at a subset of MSM, specifically young MSM, aged 13 to 24. And here you see that among the MSM youth, African Americans have by far the highest number of new HIV diagnoses per year, and also have had the fastest rate of rise in new diagnoses, again, since 2007. And these are national data from the CDC. Here again we see number of new HIV diagnoses per year by age group, and not just the 13 to 24-year-olds, but also then the 25 to 34-year-olds have the highest number of new diagnoses. And you see the rise in rate of new diagnoses in this youngest age group, and that in 2010, the number of new diagnoses in the 13 to 24-year-old range surpassed those 35 to 44 for the first time. Taking a little more local look at this, this data comes from our partners in the HIV epidemiology section. The red line shows in San Francisco the number of HIV diagnoses we had each year from 2006 to 2011. And the yellow and green bars represent the total number of people living with HIV and AIDS. And this is a positive graph in the sense that we see a decline in number of new diagnoses per year. This is great news. But we still have, in 2011, 392 people who were newly diagnosed with HIV. And so we still have a ways to go. The theme of this year's International AIDS Society meeting, for those of you who didn't make it, was to get to an AIDS-free generation. And clearly in San Francisco, we still have some work to do to get there. This graph shows the estimated number of new HIV infections per year. This is different than new diagnoses. As you know, when you newly diagnose someone with HIV, you don't know how long it's been that they've been living with HIV. This may be someone who's had HIV for many years and didn't know it, or it could be someone who was infected 6 months prior. So we have to use some statistical techniques to estimate the number of recent or new HIV infections. And again, the trend here looks good. The number looks like it's heading down, which is what we want. But these bars, which are called confidence intervals, overlap. So this trend is not statistically significant, although it looks promising. And then lastly, again, this comes from the HIV/AIDS Epidemiology Annual Report, which is available online on their website. You see the percent of MSM who reported unprotected anal intercourse in the last 6 months. This data comes from our colleagues at the Stop AIDS Project. And you see that the top line here is HIV positive MSM, and the red line is HIV negative. So greater than 50% of HIV positive MSM, and somewhere between a third to almost a half of HIV negative MSM in San Francisco have reported unprotected anal intercourse in the last 6 months. We also saw from the data Kyle presented this morning that we're seeing rising rates of syphilis in MSM, as well as rapidly rising rates of rectal gonorrhea and chlamydia. So these are all signs that there are risk behaviors going on that are putting people at risk for HIV, and we need additional strategies. So in terms of using anti-HIV medications for prevention, this is a slide which differentiates between pre-exposure prophylaxis, post-exposure prophylaxis, and antiretroviral therapy as prevention in terms of when this is used kind of chronologically. So pre-exposure prophylaxis is used prior to exposure. PEP is used just after a high-risk exposure. And then antiretroviral therapy as prevention is something focused on people living with HIV who then take medications to drive down their viral load and prevent ongoing transmission. And there are some advantages and disadvantages to each of these strategies that I highlight here. And I'll kind of start over on the right. So ART as prevention not only has a benefit in terms of decreasing HIV transmission in the community, it also has clinical benefits to the HIV-infected person who's taking the medication. Earlier this year, a randomized controlled trial that looked at ART as prevention showed that it has greater than 90% efficacy at reducing the risk of HIV transmission among heterosexuals. While we think this also will work with MSM, we don't have the randomized controlled trial evidence to support that. There's a lot of challenges with ART as prevention, and the San Francisco Department of Public Health has been a leader across the country in really trying to advocate for this strategy. But scale up is hard. It does require a lot of resources. It requires long-term adherence on the part of the person who's using ART. And there's some risks of long-term toxicity of the medications and resistance. PEP, so post-exposure prophylaxis has an advantage in that, unlike PrEP, it's a short course. So it's 28 days, and I'll talk a little more about PEP in a few slides. But unlike PrEP or ART as prevention, there's not any randomized controlled trial data that really tell us that PEP works. In addition, PEP requires that someone recognize that they've had an exposure that puts them at risk for HIV infection. And we know this is challenging. People use a lot of different assumptions about the HIV status of their sex partner. It may be that the person they assume is HIV negative is actually putting them at higher risk than a known HIV positive partner who's on meds. So you have to kind of recognize that you're at risk, and then also know where to go to get PEP and get there within 72 hours and get the drugs. And we know that all of those steps can be challenging. Again, adherence is key, as it is for all three of these strategies. But because of these limitations, we think the public health potential benefit of PEP is probably limited, although it is an important tool to have available. And then lastly, I'll talk more about PrEP later on, but PrEP, as you guys know, there have been several randomized controlled trials now that have demonstrated that PrEP works in multiple populations, both MSM and heterosexual men and women, for the prevention of the sexual transmission of HIV. So I'm going to present a case and then get your thoughts, and we're going to talk first. This is a PEP case. We're going to talk first about PEP. So this is a 35-year-old MSM who presents to your clinic for an STD checkup. His last sexual encounter was 2 days prior, and he had unprotected, insertive anal sex with a new sex partner. He's had 8 partners in the last 3 months. He uses condoms with his HIV-positive partners. He feels well, and he has no STD symptoms. His rapid HIV antibody test is negative. So the question is, would you offer this patient PEP? It sounds like there's a fair number of people, over a third, who are pretty concerned about the possibility of prescribing PEP in the setting of acute HIV infection. And in somebody who has ongoing risk, this is a real concern, and I think this is something that certainly is important to keep in mind. One thing to emphasize is that you should always ask your patient about symptoms of acute HIV, and those include, fever, headache, rash, lymphadenopathy, sore throat, sometimes GI symptoms, and take those into consideration. At City Clinic, as well as at Magnet and AHP, we do HIV RNA testing as part of our HIV testing, so we're able to detect acute HIV that may be present at the initiation of PEP. And that's something you could consider doing if you are in the community and you're prescribing PEP on your own to someone who you think may be at high risk for acute HIV. And that would involve ordering an individual HIV RNA in addition to your rapid antibody test. And I'm glad to see that many of you would refer your patient to City Clinic for PEP. Some of you would do it on your own. And then again, a little portion thought that the risk might not be high enough. So we'll talk more about that. So as I mentioned, unlike for PrEP, there have not been any randomized controlled trials that have been conducted to evaluate the efficacy of PEP. Most of the data actually comes from case control studies and observational studies of occupational PEP, or using PEP in healthcare workers who may have been exposed to an HIV-infected patient through a needle stick. PEP should be started within 72 hours of a high-risk exposure to a person known to be HIV positive or at high risk for HIV infection. It's essential that you get an HIV test at baseline. And really, an antibody test alone is the standard recommendation. I would say in select circumstances where you have a high suspicion for acute HIV, getting an RNA as well would be reasonable to consider. It's important that you provide counseling around adherence and side effects, as well as risk reduction and counseling and condoms. So to PEP or not to PEP is always kind of a difficult question, and the clinicians at City Clinic have a lot of experience talking to patients about their decision to PEP, and ultimately it always is a case-by-case decision that, and a decision that's made jointly between patient and provider. If you have questions about whether or not you think you should PEP someone, you're always free to call our clinicians consult line and talk to one of the City Clinic staff who again have a lot of experience thinking through these decisions. This table comes from the CDC. It's an HIV transmission risk table, and it shows the risk per 10,000 exposures of a number of different types of exposures. And this was updated in July 2012 and is available on the CDC website. So these 4 exposures are all exposures for which at City Clinic we would consider offering PEP. So receptive anal intercourse, receptive penile vaginal intercourse, insertive anal intercourse, or insertive penile vaginal intercourse. And again, if the sex partner is HIV positive or at high risk for HIV infection. We do not offer PEP for oral sex, or we get a lot of questions about these other types of exposures to body fluids, biting, spitting, sharing sex toys. We do not think that these exposures are high enough risk to warrant PEP. As I already mentioned, PEP is taken for 28 days. And one area of sort of confusion and controversy is what regimen should I prescribe for PEP? The CDC guidelines on PEP were released in 2005, so they're quite outdated, and a new update to those guidelines is forthcoming. And those guidelines are a little vague on this question. They say that the optimal PEP regimen should balance side effects, efficacy, and cost. If you call the PEP warm line through the CDC, often the recommendation is given to give 3 drugs for PEP. And certainly it's plausible that 3 drugs would be more efficacious than 2. But that said, two drugs, from what we know from observational evidence, seems to be adequate in almost all circumstances. We've never seen a true PEP failure at City Clinic. We currently use a fixed-dose combination of emtricitabine and tenofovir, also known as Truvada. If you are going to use a third drug, two good options are raltegravir or a boosted protease inhibitor. And there was a relatively recent study from the Fenway in Boston that looked at raltegravir plus Truvada for PEP, and found that that was quite well tolerated as compared to regimens that use Truvada plus a PI. One pearl is that you should never use the drug nevirapine for PEP because there's a high risk of severe liver toxicity in HIV-negative people who use that medication. So moving on now to pre-exposure prophylaxis. It's been about 2 years since the groundbreaking results of the IPREX study were released. And this study was a randomized controlled study of pre-exposure prophylaxis in MSM in transgender women. And it was named one of the top 10 medical breakthroughs of 2010. I think most people in this room have heard a lot about IPREX at this point, but the IPREX study enrolled 2,499 participants at 11 sites across 4 continents. And the basic bottom line here from the IPREX study is that the overall efficacy was found to be 42%. So there was a 42% decreased risk of HIV acquisition in the people who were randomized to take Truvada compared to those who were taking placebo. There were 83 infections in the placebo arm, 48 in the Truvada arm, for a total of 35 averted HIV infections. There was a tremendous amount of knowledge learned from this study, and I'm not going to have time to talk about all of that today, but I want to emphasize one really essential point from this study, which was how important adherence is to the success of these biobehavioral prevention interventions. So this is a table that summarizes the overall efficacy results from 3 different PrEP randomized controlled trials, as well as the overall number of participants in the active arm who had drug detected in their system. So in the IPREX study, which I was just talking about, the overall efficacy was 42%. And of participants who were randomized to take the drug, only 50% of them had drug in their system. These 2 studies, Partners PrEP and TDF2, are both PrEP studies that were conducted in Africa among heterosexual populations. And in those studies, there was better adherence, so 82% drug detection in Partners PrEP and 80% drug detection in TDF2. And as you can see here, the overall efficacy was quite a bit higher than in IPREX. So drawing from this, as well as a lot of other evidence, we really know that adherence is essential to the success of this intervention. Now, I do want to caution that not all the PrEP randomized control trials that have been done have shown a benefit. The FemPrEP study in Africa did not show a benefit. This was a study of heterosexual women who are at high risk for HIV. The VOICE study is a complicated study that's still ongoing, but there was one particular arm of the VOICE study that was a tenofovir-only arm. So rather than looking at Truvada, which is the combination drug, one of the arms looked only at tenofovir, and that arm was stopped early due to futility, or meaning even if the study had continued, they would not have shown a benefit of tenofovir for HIV prevention. And there's other studies, including a study of PrEP and injection drug users, for which we're still awaiting results. So it's not totally clear why there's been this difference across studies, but certainly we know that pill taking or adherence is a major reason for some of these differences. There may also be some issues with drug levels in the rectum versus the vagina that may have something to do with differences in protection among women versus men, or between vaginal intercourse and anal intercourse. And the background rate of STDs also may have had something to do with it. So in populations that had a high rate of genital ulcer disease or other inflammatory STDs, PrEP may not have as much benefit as possible. We don't know that. So based on the results of the IPREC study, Partners Prep, TDF2, in July 2012, the FDA approved tenofovir for PrEP for the prevention of sexually acquired HIV infection in adults at high risk. The FDA approval included a strengthened strengthened warning that emphasized that only individuals who are confirmed to be HIV negative prior to prescribing should be offered PrEP, and that HIV testing should be done at least every 3 months during use. They also released what's called a REMS, a risk evaluation and mitigation strategy. And two important points from the REMS are that, the goal of the REMS is to minimize the risk of acquiring HIV and to reduce risk of HIV resistance. And also to figure out really how are we going to train and educate providers to assist them in counseling individuals who are taking PrEP or considering taking PrEP. So I'm going to talk now about why we need PrEP demonstration projects. And I think hearing your concerns about PrEP is really the main reason we need PrEP demonstration projects, because there are a lot of concerns. There's a lot we still don't know about how to safely implement this strategy in the community and in clinical settings. So we're interested in looking at, will MSM want PrEP? And which MSM will and won't want PrEP? How will this differ based on things like sociodemographics and race? Will those most at risk for HIV actually want to use PrEP? And how will MSM use PrEP? What pill-taking practices will we see? Will people use it safely, daily as directed? Or will we see different dosing strategies? Some of you may have heard some of the lingo, disco dosing, taking pills just around the time of partying, which is not proven to work and could be risky. So we want to know if we're going to see that. How will sexual practices change for people using PrEP? Where are PrEP delivery systems best located? And will PrEP be safe in the real world? So this is a proposed PrEP cascade. Many of you may have seen the HIV treatment cascade, which shows the steps that are necessary between diagnosing someone with HIV and getting them linked to care. And we know that people kind of fall off that cascade at multiple steps along the way. And the same will likely be true with this PrEP cascade, which starts with first identifying just the whole population of people who are at risk for HIV and identifying those who are candidates for PrEP, making sure that there is information and knowledge about PrEP out there so that people who are interested in PrEP can seek it out or be offered it by their clinicians. People have to be linked to a place where they can get PrEP. It has to then be initiated safely with the appropriate monitoring done. And then people have to want to stay on PrEP, stay in a program, and achieve adequate adherence. So another goal of the PrEP demonstration projects is to really try to define and refine these steps in the PrEP cascade and to see where are people falling out, where are our biggest holes in terms of getting this implemented. We also want to develop and evaluate metrics for measuring each step and identify potential facilitators and barriers to proceeding along that cascade. So for my last few slides, I'm going to tell you a bit about the demo project, which we are doing in collaboration with Bridge HIV. It's a NIAID-funded, multi-site, prospective, open-label PrEP implementation study. We're enrolling 500 at-risk HIV-negative MSM and transgender women. It's a 2-site study, so 300 of the participants will be enrolled in San Francisco and 200 in Miami. And everyone will be offered up to 48 weeks of Truvada. Our primary objectives are to look at some of these key issues that we've been discussing: uptake, adherence, persistence, meaning how long, once somebody starts PrEP, how long do they want to take it for, side effects, toxicities, and changes in risk behaviors. We launched now about 6 weeks ago, and I think we've enrolled about 30. We're close to 30, if not at it. So it's been pretty brisk uptake, and the study, we're already learning so much just talking to our participants about why they're choosing to use PrEP and what their concerns are. So I mentioned that the study is being done at City Clinic as well as the Miami-Dade County Downtown STD Clinic. And the study entails coming into City Clinic for visits. All the participants are offered up to 48 weeks of Truvada for PrEP. They'll be offered regular HIV testing, STD testing and treatment. We'll be monitoring for side effects and changes in kidney function. We provide medication and risk reduction counseling at each visit, condoms, and of course the participants have the opportunity to answer a detailed questionnaire on their drug and sexual behaviors. Some of the key points from our adherence counseling are that the only way that PrEP has been studied is when delivered daily, so 1 pill once per day. We go over in detail with the participants the potential side effects of the PrEP medication and strategies for dealing with these side effects. We talk about ways of developing a routine and ways of integrating PrEP taking into their daily lives. And we talk a lot about stopping and restarting PrEP and how to do this safely. In terms of risk reduction counseling, we talk with our participants about their current sexual and drug-using behaviors and what their current HIV prevention strategies and plans are. These are all people who are motivated to stay HIV negative and that they're opting to use PrEP as a form of protection. So we really want to understand what their current strategies are and how PrEP fits in with their overall sexual health goals and plan. We emphasize that PrEP has not been shown to be 100% effective, that it does not protect against other STDs, and that frequent HIV testing is essential. So just a quick timeline of what study participation looks like. There's a screening visit and then an enrollment visit a couple of weeks later. At the enrollment visit, the participant is given 1 bottle or 30 days of Truvada, and then they're seen at 12, 24, and 36 and 48-week visits. And at these interim visits, they're given a 90-day supply or 3 bottles of Truvada. So the participants have to be HIV negative, MSM, or transgender women who are sexually active and at risk for HIV infection. We're looking at MSM and transgender women who are 18 or older, fluent in English or Spanish, have normal kidney function, and no serious medical conditions. If you want to refer your clients to the demo project, you can have them just drop into City Clinic and ask about the project. They can also call this number, 487-5537, to schedule a screening visit. There's more information on our website as well. And before I get to the conclusions, I'm sorry I don't have a slide on this, but I also want to mention that if you in the community are interested in providing PrEP to your patient, we recently have learned that Healthy San Francisco has added Truvada for PrEP to the formulary, so that is covered through Healthy San Francisco. And if you want to prescribe it to your patient and you need some advice or guidance, we're trying to work to set up some services for providers so that you can have a centralized way of getting consultative support in doing this. But in the meantime, you're welcome to call us at City Clinic and we can try to give you some advice and guidance. So to conclude, biomedical HIV prevention tools really require a combined biobehavioral approach, and demonstration projects are needed to address the many unanswered questions about PrEP. I didn't talk about this, but the demo project is not the only PrEP demonstration project going on in the country. There's demo projects in LA and San Diego. There's a small pilot in Oakland. And there's many other sites in New York and Texas where they're looking at doing demo projects also in different populations like heterosexuals as well. There's ongoing work needed to best understand how to support and train providers who are interested in providing PrEP in the community. Because clearly the demonstration projects are a tool to learn about implementation, but they aren't going to be the solution for disseminating this intervention broadly. So I want to acknowledge Al Liu, who's the PI of the project and a leader internationally in the field of PrEP, as well as Susan Phillip, Amira for her wonderful efforts organizing the STD update every year, the PrEP demo team, which is just an incredible group of people, as well as all of the City Clinic staff who have worked together to help us get this project off the ground and who provide excellent services every day to all of our patients. So thanks very much for your time. I think we're a little out of time. Not out of time, no questions? I'm sorry I didn't leave time for questions, but there's going to be a round table after Dr. Engelman's syphilis talk, so we can answer questions about PrEP at that time. Thank you.